So, respected members from IAP NRC and IAP Odisha State Branch, good evening to one and all. And today is a very auspicious day that this webinar of our fortnight academics of every Tuesday we are doing, every alternate Tuesday since last 3 months. This is the 6th episode, and we are happy to be associated with IAP NRC, National Respiratory Chapter, and happy to be with us Dr. Subramanya, who will be deliberating today with us one interesting talk on pneumonia. So we are really happy that with the help of Professor Dr. Modi, and we have arranged this National Respiratory Chapter webinar along with IIT Odisha in a combined effort. And we hope this will be a great learning for all of us today. And without much delay, I request our President IIP Odisha State Branch, because Dr. Rawat is not there, I think, and Dr. Khalatkar sir is also not there. So I request.
Rawat sir will be joining.
Okay.
Rawat sir will be joining in between. Yeah.
I request our IIP President Dr. Leena Das Madam to give the opening remarks.
Respected, good evening to all. Respected Dr. S.S. Rawat, Dr. Chairperson of IAP NRC, and Dr. Jayant Joshi, Chairperson elect of IAP NRC, and Dr. Shantanu Dev and Dr. Subramanya NK, today's speaker, and Modi, our colleague. So, good evening. This is the 6th webinar, as Mrutyunjay has told, and respiratory chapter is doing very well, and we are updating our knowledge. And today, I think the topic is next topic, basic insights into pneumonia. So pneumonia is a common problem, and every day we deal with a lot of cases. So I have heard a talk from Dr. Subramanya many times, and Modi also moderating many times. So we welcome you all, sir, and please start your talk. Modi to moderate, I think Modi will moderate.
Thank you, madam.
Over to Modi.
Thank you, madam. Before going to Dr. Modi, we have with us our President, Dr. Rawat sir is here, IAP NRC Chairperson, sir. So we request you to speak a few words for this today's webinar.
Thank you, Dr. Mrutyunjay. Good evening, all. Respected Dr. Modi, all office bearers of IAP NRC Odisha branch, Dr. Dash, Dr. Leena Das, and all my dear friends. First of all, I'd like to congratulate IAP NRC Odisha chapter for starting this academic initiative. And what better could be to start with a talk by Dr. Sonu Madam NK, who is the most sort of the speaker, and he'll be speaking on his favorite topic on pneumonia. So I think today it will be a feast for all of you, and my best wishes to IAP NRC Odisha branch carry out more such activities in the benefit of IAP NRC members of Odisha and across the country, and may you do more such activities. Thank you very much, and I think let us hear what Dr. Subramanya wants to say. Thank you very much.
Thank you, sir. Thank you for your welcoming remark. And now I request from Central IIT, we have with us our Vice President East Zone, Professor Dr. Prashant Sabat, to speak only 1 to 2 lines on this webinar today.
Mrutyunjay, thank you. On behalf of Central IAP, I congratulate the Odisha State Branch and Odisha NRC chapter. It is a great thing that our Dr. Biswajit Misra is president of IAP NRC. Really, my congratulations to Dr. Biswajit Misra also in his absence, and all respected Bhuya sir, Arti madam, and Leena madam, Dr. Subramanyam, our NRC president, Dr. Rawat sir. So congratulations to all of you that you have given full support and for this initiative of Odisha NRC chapter as well as state branch. And Dr. Modi's very much passionate about respiratory chapter. Dr. Modi and Dr. Rasmi, they are two, well-known person from Odisha who live for respiratory chapter only. So my all best wishes to them. Thank you. Let us continue with the academics.
Thank you. Thank you. So without much delay, I would like to introduce my teacher and my mentor, I can say, and Professor Dr. Narayan Modi, who is now the head of the department in the Department of Pediatrics, MKCG Medical College, Barampur, Odisha. And he is a very well-known figure now. Currently, he is the Secretary General of IAP NRC 25-26. And he has got the EB membership of IAP NRC and also the Pediatric Allergy Association of India. And he is EB member from Odisha and Central Lab in 2021. And he is a national TOT of different modules, ATM, CAD, RTI GEMS, PPP, DAD, and lot of respiratory modules. And we are telling him in our state as the father of respiratory medicine in pediatrics in our state, along with Dr. Rasmi also. And he is the joint national convener of ATM revision module and national convener in the advanced asthma course, which is a beautiful course designed by the people of IAP NRC. And now his areas of interest is allergy, asthma, and respiratory medicine. So I welcome Professor Dr. Modi to start introduce Dr. Subramaniam sir.
Enjoy for the kind introduction. So, Jai Jagannath and Jai IAP Odisha and IAP NRC. Respected Chairperson, Sir Dr. Rawat, and all the teachers who are there in this platform today in different capacities, seniors and dearest delegates. A very warm welcome to you all to this wonderful initiative by IAP Odisha and this webinar in jointly being organized by IAP NRC Odisha branch. Now, when Dr. Mrityunjaya requested me for a platform and he expected a larger audience, he requested me a platform from IAP NRC. I requested my chairperson, sir, my guardian angel, Dr. Rawat sir. He said, क्या पूछ रहा है, क्यों पूछ रहा है, कोई academic activity के लिए कुछ पूछने की जरूरत नहीं है. So this was all his kind gesture. Now, introducing today's star, our speaker, Dr. N.K. Subramaniam. It will be actually like embarrassment and crime on my part. If I am to introduce him, I won't be doing justice actually. What he has done to IAP NRC and what he has done to me personally, bringing me into respiratory medicine is something which cannot be expressed in words. He has devoted and sacrificed all his academic career to pediatric respiratory medicine and child health. All the programs that we are conducting nowadays from IAP NRC, respiratory, pediatric respiratory book, different modules, courses that just now Dr. Mrityunjaya told about advanced asthma course. These are all his actually thoughts that we are carrying forward and we are reaping the benefits all over the country, far and wide. All the pediatricians now, they are just so passionate and they're just jumping into all the learnings and courses of IAP NRC. And not to tell about his speaking ability, deliberation. He can keep any number of crowd spellbound, and with all his simplest way of communicating to the other side is simply fabulous. And he has chosen a very, very common topic, but still it is so like intriguing It is there, pneumonia word is there since 2005 years, since the days of Hippocrates. And we know that it is mostly dangerous by a bacteria since more than 100 years, since Sir William Osler. But then again, it is still the most common under 5 cause of mortality, around 20% in India. Most common vaccine preventable cause of mortality in under 5. And we are having a lot of vaccine. Even our government also has brought in vaccine, pneumococcal vaccine, conjugate vaccine in last 4 years. But still then, why it is still a problem? And that is what our Dr. Subramaniam sir is going to actually deliberate today. 5 things that I have actually noted for the menace of pneumonia, especially in our country, is nutrition. And now it is not undernutrition, it is actually malnutrition or overnutrition, even overcrowding, emerging infections. Now every other day we are hearing about one new microbe causing a respiratory illness. So they are all new. And environmental tobacco smoke, and not to speak less about air pollution. So these 5 things, I think, go a long way in keeping this pneumonia illness still a severely dreaded problem in our country, in our country's context. So now nothing in between this wonderful scientific presentation and our dearest delegate. So over to you, Subbu sir.
Dear friends, delegates, first of all, Jai Jagannath, the land from where I had lot of blessings, and I had the pleasure of visiting the himself, Lord Jagannath, due to my courtesy, my friend Dr. Narayan Prasad Modi, just a month back. And I wish that all our political missions, including my candidature for the prestigious Honorary Secretary General of IAP, would be in place. And I could see Deepam there. And I was very much blessed. Thank you, Modi, personally on that, making that opportunity for me in my life to visit Jagannath, from where anything and everything can start. I have got a couple of emotions here. Please bear with me for only 1 minute, but from there I will take on pneumonia. We have got many names over here on the screen. How many of you remember General Rawat? All of us. He was the soldier, and we have the best soldier, the first soldier of respiratory chapter with us, and my dear Sanjeev Singh Rawat. He is synonymous with that military kind of approach. And I will tell you, I was proud that I was lucky to be the chairperson when he was secretary. I don't say he was my secretary, but I would say I was the lucky chairperson of him as the secretary. I'm telling you this very openly. When I was secretary, he was the EB member. Then I choose a couple of them, Narayan Prasad Modi and Rawat sir. Let me be very honest. I'm opening those secret box for all of you. Modi sahab told, "Abhi mere ko 2 saal de do, Rawat sahab ko banayenge." So this was those days, and true to his words, he did so many surgical strikes in his times that, for years together we remember them. There was one vision from me. It was very quickly converted into mission. A dream is possible from a leader, but realizing the dream is something exemplary, and it requires a lot of hard work. I myself know as a secretary of the chapter, and therefore I compliment our professor, Dr. Rawat. You have done each and everything. A day may come when you will also be invited and be told your contribution to the chapter goes in the history. So to that extent, we were one of these honorable, the secretary of the IAP used to call us Modi or Shah Jodi. You know, I still remember this, and that was the kind of sync with which I worked. But the legacy continued, and then it was Dr. Rawat and Modi now. What a continuation we are having. And you know, now we have Modi, whom we are now seeing on the news channels as one of our leader. We are looking forward for keeping that name of Modi at high stakes. We have both Narayan and Modi together. So therefore, Jagannath and Modi together makes a huge combination for us. And I would wish lot of things can happen from NRC. Mrityunjay, your name goes with lot of life to our soldiers, and therefore I'm just taking the names. Lina Madam, Dasji, Namaste, and Boyan Sir, Namaste, and Santanu, and Kashi, everybody. I'm just taking the names only because I have to acknowledge, as a soldier of the respiratory chapter, the kind of contributions that you all made. No war is won from anyone. It is won from the team. And you are all there in the team. Santanu, you could also recollect how active you were in the respiratory chapter, making that entire cough module, which is now in the mouth of everybody. So therefore, it is not from anybody. Please, I don't take any credit. It's the teamwork. Like in India, what they are telling is Navy. Everybody is telling no, Navy did not strike. It was just standing rock solid behind. It was the air that strike, got the name, but it was the military who fought us. So the respiratory chapter story more or less gets linked to the current world. Now, let me just start my talk. Let me just start my talk today. Modi bhai, anything that you wanted to tell?
Sir, you have only 40 minutes for the talk.
No. I'm getting into the topic only. Now, when we were trying to hit Pakistan, we were confused whether we are hitting political Pakistan, military Pakistan, territorial Pakistan, revenue Pakistan, land Pakistan, what? Same problem exists with pneumonia. Please understand, are we hitting the organism? Are we treating the child? Are we treating the respiratory system? See, the problem is always, if we have not analyzed and understood pneumonia, it will be same kind of failure of operations of missions on the other side. Actually, for this understanding, I will take you through the journey in the next 30 minutes. I've got only 40 slides to share, but lot of messages and lot of thinkings. There is no need for me to give you which antibiotic to choose, which X-ray to do, which test to do, which I will pass through. But remember, have we understood what is pneumonia? That's why I told you it's a basic consideration. And whenever we want to hit, we should know what we are hitting, why we are hitting, how we are hitting. So therefore, let's all join for the war on pneumonia, and let's understand from this perspective. Then you will be really through the slides, and therefore it is same as Operation Sindoor on pneumonia. So let me take you through this, and that was the reason why I was taking some time for that introduction. Now, what is that? It's pneumonia. A pathologist describes it as inflammation of the lungs, pneumonitis. Radiologist calls it as areas of consolidation or fluffiness that I would see on a chest X-ray. A microbiologist relates it to invasion of the lung parenchyma by the organisms specified. And some immunologists say it is different when it is immunocompromised or immunocompetent host. Somebody says in newborn there is nothing like pneumonia because any infection is systemic. And somebody says that no, it's very, very important for us to recognize the organism has come from the hospital or from the community. And therefore, he says this should be divided into community acquired and hospital acquired pneumonia. I think this picture speaks volumes. We look at pneumonia from our own understanding. If you're a pediatrician, you will look this as the pneumonia. If you are, for example, Modibai, if you are an adult physician, You are treating a smoker and a chronic smoker, and he has COPD and he has a fever. Whether it is injury, whether it is pneumonitis, whether there is primary bacterial invasion, secondary bacterial invasion, so many. Is it colonization versus infection? Is it inflammation only? Or there are hundreds of questions which can be asked, but there are few answers that come for us. We always use it for justification for giving antibiotics. We use this for justification for sending investigations. The word pneumonia is understood as well as misunderstood. Somebody said that counting of respiratory is for ASHA workers or health workers, not for the pediatricians. And therefore, my dear friends, let me take you through thought process on pneumonia. Please, I will request you and I'll beg you, you can go to literature and read everything about pneumonia. We have got a module. We will run the module for you if you want. But please focus today on what is pneumonia. Now, let me come to that. I Googled, and these 30,000-40,000 responses came from Google on pneumonia in childhood. Let me Google and see. I will just tell you how I went. Please join my journey. It's wonderful academic journey. And this is the images. I just Googled on non-image. I could get around not less than 5 lakhs, millions of responses on pneumonia. Then what is that we are talking? Is it flooding of definitions? Is it flooding of messages, or is it flooding of information? What it is? Next. Then I went into basic question asking, is it LRTI same as pneumonia? Or pneumonia is different from LRTI? I would say some LRTI are pneumonias and every pneumonia is an LRTI. This is again a tricky question. And why I'm asking this question, Madhibai? Many people, sorry, I will take your name now and then because you are moderating. The issue is that pediatrician doesn't want to commit pneumonia, and therefore use the word broad spectrum LRTI. So I can give nebulization, I can give salbutamol, I can give antibiotics, I can give SOS, inhalation, corticosteroids, and give a combo therapy to get away from the LRTI. And he will say, I will take an X-ray to look for pneumonia. So, my dear friends, it is definitely a gray area. Are you not seeing that this is a gray area? Consolidation. Who has seen the consolidation? So I would ask for those of you who say pneumonia is consolidation, is right upper lobe consolidation treated differently from left upper lobe consolidation? Is it that consolidation is a prerequisite for pneumonia? If there is no consolidation, either clinically by examination or by radiology, I'm not going to treat as pneumonia. I think I have confused you enough. But I'll tell you, what about those which cause injury and inflammation in the lungs, but not necessarily due to infection? For example, a chemical aspiration, a lipid aspiration, or an inhalation of a irritant would also cause inflammation of the lung and its pneumonitis. There are lots of doubts on to give or not to give antibiotics. Kerosene poisoning, kerosene aspiration for that matter. Are you all getting that point? So therefore, these are the circumstances where you have a lot of issues and dilemmas. Now, is it means that we should look at secondary infection requiring antibiotics is what is pneumonia? In that case, every viral disease, there will be a justification for giving antibiotic as a secondary infection. And then it is not over. It goes further to tell you that it is defined as not an URTI. That is what you see in WHO definitions. My dear friends, there are other terms that are frequently used synonymously or confusingly with pneumonia, viral associated with wheeze and bronchopneumonia. Let me ask on the chat box. Don't be a passive listeners. Please type on the chat box and let's know. Do you think that I'm very happy? Please type, yes, sir, we are confused. No, sir, we are not confused. If you are confused, please type yes. And let me see what is your response. Please type and interact. So that's the way that I can move forward. Please type yes. Am I able to see yes? At least. Okay. Madhiba, I'm not able to see. That's fine. No issues. Probably there must be some responses. Okay, good. Done. Okay. So now, therefore, my dear friends, what I need to know from you is that I'd be very happy, at least if you have questions, raise for yourself. Now, the next issue that is coming is this pop-up of community acquired pneumonia and where we are today. Now, I went to WHO website to look pneumonia. This gave me some kind of different type of insight. Pneumonia is form of an acute infection that can cause death and can affect all children caused by virus or bacteria. What does that mean? Now, the definition of pneumonia by WHO is more or less a definition of a problem rather than definition of a disease. And a clinician sitting in the office wants it as a disease, not as a definition. I went to the UNICEF website to see, again, this is a problematic definition or a disease burden to be tackled rather than definition of pneumonia. I'm very happy when many people are writing. Definitely, I'm asking the question basically what it is, what is. If I don't answer you today at the end of the talk, what is pneumonia, definitely will not be able to treat a pneumonia. No issues. Don't get confused. Good that you get confused, but do not worry. Now look at the Ministry of Health and Family Welfare, IMNCI. What it did, instead of defining pneumonia, it was only defining the severities of the illness. Somebody in the green zone, somebody in the yellow zone, somebody in the red zone. More than defining, they were triaging the severity. I think, please understand, do you all agree? So they have to take a call whether it is to be treated upfront, to be referred, not to be hospitalized. These were the questions are answered, but not pneumonia. Let me go further. I was looking at STG, our IAP standard treatment guidelines, which also said acute parenchyma infection in a healthy child acquired outside the hospital, not hospitalized 14 days prior to the onset of symptoms. This excludes the children from immunodeficiency, malnutrition, post-measles. So this looked like a definition of attempting to define community-acquired pneumonia. Now, if I ask you the broader term pneumonia, then again there are issues. Okay, fine. Now, what it means is that, let me ask you a question to confuse you. You have an immunocompromised host and you have a colonizer. Do you want to treat? Is it pneumonia or pneumonia? Do you want to wait for the fever? It is impossible. There may not be immunological response like total leukocyte count or a consolidation that can happen. So, my dear friends, therefore, pneumonia is at present enigma in my talk. Let me see if at the end of my talk I can answer to all of you. We did attempt from the respiratory chapter, National Respiratory Chapter, when I was the secretary. This was again 2 to 3 years of efforts. And then we could finally come out with pneumonia in children. Large part of it is contributed by our Rawat, Dr. Modi, and Dr. Rashmi Ranjan Das. The studies that were conducted, multicentric studies, there's a lot of data. Again, here also, we were taking you through the journey of it. While defining, we had issues, but somehow we could sail through because we were not, focused on the current commitment that I am talking to you right now. Again, I will go back to WHO because it's a global problem and there has to be reduction in the mortality of pneumonia. Let us look at what is causing our death. So actually, WHO treatment and classification is solely based on the severity classification. You look at what is the WHO older definition: cough, cold, no pneumonia, pneumonia, severe disease. Now currently no pneumonia, non-severe pneumonia and severe pneumonia. What does that mean? They mean that pneumonia is a spectrum from no infection to a severe disease. Somewhere at some cutoff point of time, we will say, yes, we'll go for antibiotics. And I think a couple of you can just type AG, agree. What does that mean is, look here, if you have cough, cold, and no pneumonia, do not give antibiotics. Somewhere if you start getting fast breathing, plus or minus chest syndrome, give an antibiotic. And if it is a severe disease, hospitalize and treat as well as give antibiotics. Am I correct? That was the message that we are getting from WHO. This means to say that pneumonia is more or less looking like a spectrum for us. I'll go further. The game changer in the approach to pneumonia was a beautiful study from Lahore, which said that oral amoxicillin replaces cotrimoxazole. And it went on further to tell that 3 days of amoxicillin is as good as 5 days of amoxicillin. You need not have to give one for 7 to 10 days. So, my dear friends, somewhere down the line, we were also confused about whether, we should give shorter courses for a severe disease like pneumonia. Because for many, pneumonia suddenly means something on the X-ray, something on the count, something coming in the cultures. And can I just give oral amoxicillin? So therefore, my dear friends, when you define on the lines of WHO, just an evidence of fast breathing plus or minus chest in drawing, you give oral amoxicillin. It does not take into account those confounders of fast breathing, which can be non-pneumonia, like bronchiolitis and others. WHO has an approach, and it has a reason and a rationale with the symptomatology. Without symptomatology, they are not telling. So in that cough and or difficult breathing with fever, etc., if you have these settings, then you would definitely give. What does it mean? If you have a clinical syndrome, then you can give amoxicillin if there are qualifiers in that spectrum of our approach. This is exactly what I was talking to you. So, if you carefully look at this WHO table, it means only one thing to me, that you can give oral amoxicillin and yet be happy. It is same as our drones, who can do multiple work. There is a wonderful all-round work our drones have done. And I would equate that oral amoxicillin for drones that we have used recently. They are low cost, cheap, hitting from where you are sitting, and serving the purpose, avoiding hospitalization and death, and is universal, unique. And amoxicillin has got wide safety range. Doubling the dose does not kill the child. Some health worker by mistake gives one tablet extra, absolutely no problem. And thirdly, increasing doses of amoxicillin is going to overcome the resistance, which is not there in many drugs that as a property. And escalation can be just by adding clavulanic acid as well, apart from and whenever you want to step up or step down, you have both injectable as well as oral preparations. If you start ceftriaxone, you don't have an oral counterpart. But if you start amoxiclav or amoxicillin, you will have an oral counterpart that is available. So that makes me oral amoxicillin Virat Kohli of cricket. Fits in either for chasing or for making runs or for in all formats of the game like T20, etc. So man of the match for pneumonia would be amoxicillin for obvious reasons. Now, if you wanted to say in one line, interpretation of this slide to me as a war on pneumonia, you classify the pneumonia into two categories. One where you need not give oral amoxicillin, that is no pneumonia, where you can give oral amoxicillin, that is non-severe pneumonia, and where you need something more than amoxicillin, that is a severe pneumonia. Now, even the chest in drawing, which was considered severe pneumonia earlier, is now considered as non-severe not because the severity is reduced, because we can manage with oral amoxicillin. That is the message, and that's very, very important for all of us. This is the study which I was talking about it. I would request all of you to read this original article. You can send to me the message. I will share this article PDF for you. Wonderful article. This is also available in WHO website. So, my dear friends, when we are looking from CDC, IAP, PubMed, WHO, UNICEF, even the ministries which are looking at it as a problem, what is pneumonia? Basically, we are coming to one point. Do I need antibiotics? Do I have to give antibiotics? Okay, I'll refine the question, do I need to start oral amoxicillin? So that's what is the question. Let me take you through your desktop or to the area where you are practicing. Let's say there is a gradual onset of fever, cough, and then following URTI, there is an LRTI with bilateral disease and wheeze. This is typical viral disease and a bronchiolitis. This we see in practice. Second, we see sudden onset of fever, dry cough, fast breathing with or without localization. This is what we see in community-acquired pneumonia. You can have a gradual onset of fever, malaise, sore throat, dry cough, joint pains, extrapulmonary manifestations. This you can see in atypical pneumonia. You know, this definition will not fit into atypical pneumonia now, dear friends. Prolonged fever, weight loss, adenopathy, and cough can be TB. My dear friends, there is no tachypnea in TB to start with. So, my dear friends, therefore, TB also causes pneumonia. Please understand my point. So, poor response after treatment can be because of resistant organisms. On the other hand, the nature may not give you time. There can be rapidly progressive staphylococcal pneumonia, which is taken by storm. You can have systemic disorders with lung involvement. It could be autoimmune disease, malignancies, brucella, lepto, rickettsia, melia, so on and so forth. My dear friends, you can get spectrum of issues that you can call them as pneumonia. So, my dear friends, therefore, it takes me through the spectrum of LRTI in my practice, and you have to sort out pneumonia from that. Now, which is the best classification of pneumonia? Inflammation, infectious, non-infectious, clinical, radiological, simple, complicated, based on the host, no pneumonia, severe pneumonia, which I have heard now, community acquired, hospital acquired. I tell you, my dear friends, I have to give you some clarity. I can't go on confusing. 6 and 7 are very, very important for us. One, you need to know from where the infection has come, because I told you it is all boils down to one question: should I have to give amoxicillin or antibiotics? In that case, I should know whether it's community acquired or hospital acquired, so that I will know which one can I give amoxicillin. Yes, if it is community acquired. If it is hospital acquired, we don't know. Please understand my point. Are you getting my point? So we need to have the answer for the seventh one, community acquired or hospital acquired, which is very, very important. And that's why the most appropriate definition for us, when we say pneumonia, by de facto, we mean community acquired pneumonia. And second, after knowing pneumonia, after knowing the organism, next thing is the severity. And severity is best done with a WHO classification: no tachypnea, and tachypnea plus increased work of breathing, which is no pneumonia, and severe pneumonia and disease. So, my dear friends, I think there is some clarity now for you to understand. Pneumonia is the killer. And why it is a killer? It's because of problems in the diagnosis, clinical signs and symptoms. Clinical signs and symptoms are not marked in non-severe disease. In a severe disease, you will have tachypnea, work of breathing, grunting, whatever you want, evidences are there. Chest pain, you understand? When it is non-severe, it may be very, very difficult to pick up. Are you getting my point? Your 5 respiratory rates short by WHO definition up by 5. Cutoff is 50 and you are 45 with tachypnea. See, are you getting my question correctly? So clinical definitions have their own problems. Radiology, if you do too early, X-ray is normal. If you do too late, then X-ray is abnormal. But the problem is, what is the use of doing X-ray too late? Microbiology, what type of microbiology we are doing? Can I isolate? Can I do a direct lung puncture? Answer is no. Can I do a blood culture? Yes, blood culture is good. But the point of blood culture is it will tell you about bacteremia, not about pneumonia. Can I do throat swab? It has got commensals. Can I do bronchoscopy, lavage, and isolate organisms? Possibly yes, but how it is available in the given the number of children who are dying from pneumonia? My dear friends, can I do PCR? It's not widely available across the country. So therefore, my dear friends, I will take you through the journey of how do we diagnose pneumonia, how can we face challenges. The next question is, what is the etiology? Now, etiology is it infectious, not infectious, if it is infectious, which organism? Now, if you want to go further, what about severity and complications? I think till we have this high mortality, we should focus on severity and complications, because, my dear friends, that is the killer. If you look at WHO, And if I ask you, why should I follow WHO? It is because it addresses the severity and complications, my dear friends. WHO is not telling you whether pneumonia or pneumonia. It is triaging. It is helping you to assess the severity when you get into the problem, my dear friends. Therefore, what it means to a practitioner is you need to confirm the diagnosis, basically, clinically, over and above investigations. If you do investigations unnecessarily, you will fall into the trap of normal counts or high counts when there is no pneumonia. Because of hypoxia, viral disease can have high counts and you will get into problems. CRP is raised whenever there is a problem. Just it is like TRP of the television channels. You know, there is a breaking news of CRP for every mother who comes to you with the children, and it's very, very difficult. And the clinical symptoms and manifestations change with the age. A teenager doesn't behave the same way as a newborn when it comes to pneumonia, but still we have some clinical features of symptoms and signs which I'm coming to. Organism, my dear friends, is a matter of proving in the lab by investigations or by an epidemiological guess. My dear friends, ask yourself what you have done. You are giving empirical therapy. What does that mean? You are making an epidemiological guess, not investigation. Suppose some organism grows in the culture, Bogdarella, whatever names that you can't identify. Again, no, Baba, I don't want this. I'll just treat pneumonia from the way I know. Are you not treating epidemiologically? Have you not epidemiologically diagnosed COVID and treated? Have you not epidemiologically diagnosed plague? Have you not epidemiologically diagnosed the last adenoviral infection and pneumonia? My dear friends, now there are outbreaks and no outbreaks. Diseases are epidemics, outbreaks, or they may be endemic. My dear friends, we have learned as clinicians how we can make an epidemiological diagnosis. Now, let me also ask you a question. What I meant by epidemiological diagnosis, organism is a function of age. It is not that at that age that organism is common. What I meant was that when you want to hit empirically, hit well, both gram positive and gram negative when they're young. Hit the organisms like strep pneumonia, viruses, and others when you are in the childhood age group. And after 5, when the probability of deaths from under 5 mortality is less, it is also probable that the same organisms may not be there because either because of the passive immunity or because of immunizations, there is some outgrowing of the immune system in the child. Therefore, when the pneumonia happens, possibly think of organisms other than the routine also. It is not that the routine organisms are not common. Also consider organisms like mycoplasma. When it comes to severity, my dear friends, there's only one physiology. It is hypoxia based. And hypoxia is diagnosed by clinical means of compensation, either by increased work of breathing, by retractions, by indrawings, so or by cyanosis, or by measuring the pulse oximetry. My dear friends, that's how you diagnose the severity. So, organism, I will retreat and repeat for you, is a function of age. It is not by hitting the cultures. We assume it is by basic assumption. And both in severe and non-severe varieties of pneumonia, the pattern of organisms remains same. Why we treat even viral pneumonias with antibiotics at times? It is because till the deaths are very high in pneumonia, it may not be possible for a clinicians to differentiate a viral consolidation from a bacterial consolidation, my dear friends, and therefore it ends up taking an antibiotic for the pneumonia, behest or irrespective of the outcome or the recovery. I cannot afford to ethically withhold an antibiotic as long as the deaths from pneumonia are very high. So, my dear friends, when the pneumonia deaths reduce to 1% or 2%, maybe we'll ask the pediatricians and health worker, unless you have a PCR evidence, unless you have a blood culture evidence, don't give antibiotics. Like we are telling now, don't give anti-tubercular drugs until unless you isolate the organism and you have proof of rifampicin resistance. Yes, no, then only give ATT. Was this the same story 20 years back? No, clinically suspected TB we were giving. Why? Because the disease burden was very high and we were very much right. When we made the clinical diagnosis in those days, because of the prevalence of the disease, not because of accuracy of our clinical diagnosis. A lot is discussed in classes, many webinars, many conferences. These are the features of bacterial pneumonia. These are the features of viral pneumonia. These are the features of mycoplasma pneumonia. My dear friends, you can be cheated because no organism will read the textbook. No child will read the textbook. None of the organisms are listening to our lectures. You can have consolidation, you can have crackle, you can have various permutations and combinations. You can reasonably go closer to either bacterial, viral, or mycoplasma. One hint I can tell you, mycoplasma size is in between a virus and a bacteria. It is a bacteria without a cell wall. Did you understand? And therefore, clinical features of mycoplasma can be in between a bacterial and a viral etiology. It looks like a viral pneumonia at times, and if you look from this end, it may look like a bacterial disease. Are you getting my point? Viral disease because of extrapulmonary features, bacterial disease because of its pulmonary features. So therefore, my dear friends, when you are confused, probably have a thought, it can be mycoplasma. There are answered and unanswered questions. Infections can be mixed. Some people start telling that I can't say it is strep pneumonia only. There can be more than one organism. Our explorations of RT-PCR, PCR testing has given multiple organisms in question, and we do not know which we are hitting, probably because we are resorting to broad spectrum antibiotics like amoxicillin and ceftriaxone. Whether there is mixed infection or otherwise, it is taking care. Can an etiology change? Yes, to start with it is chickenpox or measles, can end up with staphylococcal pneumonia. My dear friends, how many of H. influenza pneumonias have become necrotizing pneumonias have ended in staphylococcal treatment? So, my dear friends, please don't be dogmatic on labeling a pneumonia to a single etiology. You should keep changing your dynamics. These are some clues, and those of you want these slides, I'll share with you. Send that WhatsApp to me. You can just have this on your table. And when you have an empyema and a large empyema, think of strep pneumonia. Small empyema, but severe toxicity, you think of staph. MRSA, if there is necrosis, crowding, contact, compromised host, or a contact with another MRSA, or immunocompromised and nutrition, or less than 3 months, think of an E. coli. It looks like a viral, you think of H. flu. And if you have children with low airway defenses, think of low-grade organisms. And these are the antibiotics that you need to add. Hypoxia is the killer, and hypoxia is because of either severity or complications. Hypoxia is measurable by pulse oximetry, not by stethoscope, my dear friends. Please buy a pulse oximetry. If your pulse oximetry, if you're not using in the OPD, start using them in the OPD. Now, I'll only take another 10 minutes to cover. Let me tell you one thing. You count respiratory rate. If the respiratory rate is 20 or 10 more than the expected cutoff for pneumonia, then it is severe pneumonia. Let's say an infant cutoff of tachypnea is 50. If it is 70, it is severe pneumonia. The cutoff for a child is 30. And if it is 50, it is severe pneumonia. You got my point. Or on the contrary, if you have hypoxia, definitely it is severe pneumonia. And if there is capillary filling time, and if there are compensation and decompensations of the chest wall and mechanics of respiration, like recessions, grunt, flare, cyanosis, etc., then also it is a severe disease. These are the red flags. When I would say red flags, it means that if the pneumonia crosses the chest, goes to the CNS, goes to the cardia, goes to the abdomen, goes to systemic features, please think of it's a severe disease and red flags. My dear friends, I'm coming back to my question of that elephant and 10 blind people. WHO definition is not about pneumonia. If you carefully look at it, is about hypoxia. Hypoxia is not anticipated in cough and cold. Hypoxia is expected, but is not clinically evident in non-severe pneumonia. But in fact, tachypnea and chest indrawing is a response to hypoxia, but that is compensated. Non-severe pneumonia means it is compensated. If it is decompensated, then it is severe pneumonia. Are you getting my point? So WHO definition is about spectrum of the disease. WHO definition is also about no hypoxia, compensated hypoxia, and decompensated hypoxia. Chest drawing is therefore now an OPD management because of our breakthrough on amoxicillin. Why count respiratory rate for 1 minute? My dear friends, it is not to define pneumonia, but to know, not to know the severity of pneumonia, but to know the severity of hypoxia. Pneumonia is not the killer. Hypoxia is the killer. My dear friends, do you think non-hypoxic pneumonias die? No. It is only pneumonias with hypoxia they die. And therefore, you need to count the respiratory rate. Don't count for 15 seconds, multiply by 4. I have had all kinds of problems in counting. Many mothers resisted me counting. Make a habit of counting the respiratory rate. Please expose the child properly and count. You please remember, physiology comes before anatomy. Signs of consolidation come after the signs of hypoxia. So no chest X-ray in the beginning. It is the physiology that alters. Unfortunately, we go for anatomy before physiology, which is unfortunate. Tachypnea is physiology, my dear friends. It's not seen on X-ray. Tachypnea comes much before you would see on X-ray, and therefore count the respiratory rate. Understand why tachypnea happens. Now, if you are an adult and if you have a good chest, please look at my hand now. This is the adult chest, and it expands, and large amount of volume of the lung is in its bases. When you have hypoxia, it responds by expanding its base. I'll ask all of you a question, and just I will take 30 seconds extra from you and ask you a question. Suppose you are imminently facing some blast and you are going to get smoked in the area, or you are jumping into a well and you have just touched the waters. What will you do? You will gasp. You will take a deep breath and take a respiratory reserve. What does that mean? It only means that an adult has a very good compensation of increasing the depth of respiration for an anticipated hypoxia. What a baby will do. Can it take a deep breath? No. Babies are shallow breathers. Look at the lung mechanics. It will take 1 hour for me to explain to you a conical chest, non-horizontal ribs, non-bucket handle movements that cannot expand the lungs, my dear friends. So infant or a newborn chest can only rock, but not expand. Rocking. And therefore, what do you mean by rocking? It responds by tachypnea. What does that mean? More the tachypnea, more the respiratory rate, more is the probability of pneumonia being there. And therefore, my dear friends, sensitivity and specificity of tachypnea in diagnosis of pneumonia is more than 3-4. That means around 60 to 70% sensitivity specificity is there for tachypnea in diagnosis of pneumonia. Aptly, correctly, because we are under 5 and over 5, the respiratory rate is very small and it doesn't change much. Did you understand what I meant by that? Or if you're driving a car, your speedometer of the car is accurate between 40 kilometers per hour to 100 kilometers per hour. When it shows 140, it may not be actually 140, but when it shows 70 kilometers per hour, it is actually 70 kilometers per hour. When it is showing 0, it may not be 0, it can be 0 to 5. Are you getting my point? Tachypnea in that range is definitely sensitive indicator of hypoxia as well as pneumonia, my dear friends. And age is therefore an important factor because age is also a factor that determines the respiratory rate. Age is the factor that determines the compensation. And therefore, my dear friends, when you have abdominal breathing, diaphragmatic breathing, when you have decompensation, should be remembering age is an important factor. And therefore, we treat the age, not the pneumonia. If somebody is having tachypnea below 3 months of age, we treat the age. If somebody is between 3 months to 3 years, we treat the age. And somebody is above 5 years, I treat the age, consider macrolides. My dear friends, symptom analysis will tell me fever, cough, and tachypnea have high negative predictive value, which means they help to rule out, not rule in pneumonia. That means these are non-specific signs and symptoms. Chest pain, workup breathing, hypoxia are specific signs. The problem is They come late in the illness. These which we have been teaching in colleges, crepitations, rails, V's, Ronchi, etc., have likelihood ratio of 1, which means that head or tail, when they are there, pneumonia can be there. When they are not there, pneumonia need not be there. My dear friends, we need to prioritize the symptoms. When you have weak, 12% likely that pneumonia is absent. I'm going to take only last 5 minutes for you. Chest pain is there, more likely of pneumonia. Young are vulnerable. They can't respond with compensation. They need to be prioritized and treated. Treat the age, treat the young, because they don't mount a compensatory response. And these are the problems of a chest wall of a child which can respond to pneumonia and hypoxia. Now, if you say, sir, if it is only counting the respiratory rate, why a pediatrician is required for pneumonia? Because by only counting the respiratory rate, my dear friends, there are chances of both overdiagnosis and underdiagnosis. Overdiagnosis can happen when there is over-anxious parents and pediatrician, two young children, bronchiolitis, asthma, relying on CBC, CRP, chest X-ray. You can overdiagnose pneumonia. You can underdiagnose pneumonia when you wait for tachypnea, malnutrition, immunocompromised, newborn, multi-system presentation, incomplete examination. All these can lead to underdiagnosis of pneumonia. Please remember this slide so that you know you are very, very careful when these patients present to you. Last slide of mine. My dear friends, the whole world is black. It is battling on pneumonia. At least our country has high disease burden. We have a couple of countries neighboring to us which also have high disease burden. We have got poor children. They beg for a meal. There is overcrowding. What should we treat? Should I do PCR testing for diagnosis of pneumonia? Should I do a chest X-ray for all these patients? Should I hospitalize them? Should I treat them in ICU? Should I give antibiotics when there is just URTI and make them spend 100 rupees? My dear friends, you have to ask yourself. You can't say I got the license of MBBS and therefore I will treat each and everything from my fancies. No, we have got responsibility. We have got pediatrician responsibility. We have to behave like India, which behaved in the recent war. We have to be responsible soldiers for pneumonia, my dear friends. Now tell me, what is pneumonia? I will leave it to you. I have answered to you. Treat the age. Treat the severity. Treat the hypoxia. Treat the host. Treat the disease with high probability of a bacterial disease till you achieve under 5 mortality to a level before which you say, I will not go as clinical diagnosis is the gold standard of diagnosis, sir. I will go for lab and chest X-rays and host of other fancy tests. My dear friends, this may not apply to hospital-acquired infections, severe diseases where you may have to do ultrasounds, which I agree. There you are not trying to use that modalities for diagnosing pneumonia, my dear friend. It is to detect complications. I never say do not investigate to detect complications or the severity. My dear friends, just to diagnose pneumonia and upfront start treatment, you don't need anything but a simple sound clinician with a perfect understanding of definition of pneumonia. Therefore, we should salute and say WHO definitions are not for health workers, they are for pediatricians. And I think now you know, don't call this as a tail, don't call this as a leg. My dear friends, they have understood the whole elephant, I suppose. If there are still doubts, I'm very happy to answer. And thank you very much. I will hand it over to the our Modi Bhai and Rawat sir, Mrityunjay, and everybody. I have just taken it as a war on pneumonia. Please increase the understanding. You should have perfect strategies and why a clinician is required for making an appropriate diagnosis of the problem. I will leave the house. You can all read about further on pneumonia. I'm not worried. I've given you the basic insights into the problem and definition of the disease. Over to all of you.
Thank you. Thank you, Subramaniam sir, for this wonderful, engrossing, and very innovative thoughts about pneumonia, this common illness, and pediatric pulmonology. In fact, the two of the more common problems, that is one restrictive pneumonia and another obstructive asthma. Now these two conditions and presentation, they will invite maximum of questions and maximum of this confusions. We have lot many pouring in, and we'll just pick up quickly. Now, one dear delegate, he has actually vented his sentiment, telling that he is completely lost. He is getting lost already. So that's the mood of the house actually. Everyone.
Don't get lost.
Na-
We have NRC to hold your hands.
Yeah.
Nasal respiratory chapter is strong enough. Don't get lost. Please get in. First get confused,
No,
then
yeah,
get
yeah,
clarified.
yeah. Initially, 90% of the presentation, everyone actually getting lost. Then they regroup and they have come back again. Another hardcore nationalist, what he has pointed out is, we don't really believe Pakistan generally. So how come a study from Pakistan should tell us that what antibiotic to give, when to give, and how long to give? So we are not going with amoxicillin or something like that. That is the question of one of the hardcore nationalists from our country.
Now, I respect that, but one thing is that not everything is bad in Pakistan. And let's come to that point. This particular study from Lahore was a really eye opener, and I'll tell you why they got into this study was because they could not afford to treat pneumonias in Pakistan, and this study was really good study. Please, I am not coming in the emotions of nationalism, but please read this article.
Now, Dr. Mrutyunjay, he has asked, what is the role of sending blood culture in all pneumonia?
Okay. Now, I will answer to you with evidence-based medicine. If you have a setting of, for example, a strep pneumonia situation, I'll take that because pneumonia is a spectrum. No, if you're looking at that, around 10 to 15% of the pneumonias are bacteremic. That means if the culture grows, then you are okay. If the culture is negative, then you are not okay. Number one. Number two, if you have a hospital-acquired pneumonia, then definitely blood culture and even tip cultures, all other catheter, etc., whatever you do, has got some relevance. And third, if you have an immunocompromised host, that means the chances of bacteremia, viremia, fungemia is more because organism growth is unchecked. Then the blood culture has a role. Fourth, if you have a systemic illness with secondary lung involvement, for example, like a newborn, which starts as a sepsis, but later on get into the lungs, or start as a sepsis, get localized to the joints, all the more the role of the blood culture is very important. I've given you 4 indications for proper blood culture. Where the blood culture cheats me, if you have a staphylococcal disease with empyema, you send the empyema for culture, pus for culture, it comes no growth. Does it mean bacteria is not there? Answer is no. You have pneumatoceles, blood culture comes negative. So aggressive necrotizing pneumonias in the lungs or in the pleural cavity, you need not have the blood culture. I think, Mrutyunjay, I gave you the complete answer on the blood culture. When you send culture, send properly. Don't keep it in the refrigerator and cause more problems. And always tell the microbiologist, please inform him about what you want to grow. Also tell him which antibiotic is already being received, so that somebody has already given one shot of meropenem and sends referenced elsewhere. You please inform that microbiologist so he will have something to do homework in the laboratory to grow appropriate.
Thank you, sir. Thank you. Thank you so much.
You are very apt, Subramaniam sir. And adding to that is, and there is another hindsight why our efforts in actually growing an organism in blood culture for pneumonia is futile almost all the time is, by the time a patient, a child reaches us, he has already had got the antibiotic. Even in our hospital, even if a child comes directly to us, even in an Apex Institute, our resident or doctor receiving the child already has started him on ceftriaxone or meropenem before we actually do the blood culture. We send the samples. So that is the most problematic thing and concerning thing in isolating the organism. And
My only take on the blood culture is that it will not help you while you are starting the antibiotic. If by the time the reports comes, it is around 3 or 4 days, by then your treatment is almost nearly complete. But if the patient doesn't respond, it will form a real good input for you to really explore and think in which direction you can escalate. That's very, very important. So don't leave the habit of sending cultures.
in non-response or partial response, even in a complicated pneumonia or a recurrent pneumonia, I think sampling is really helpful, and sending it to a proper lab. So these three things are most important in isolating the organism. Now, another dear delegate, he has asked treatment of viral pneumonia.
There are two things that I want to tell the delegates. A viral disease as an extension of upper respiratory tract infection. I will have a cold and I will have couple of wheezes that come as a part of syndrome of URTI. Don't give antibiotics. There is a natural history. I'm just referring to 1 or 2 invasions of lower tract, but predominant syndrome is URTI. Am I clear? That is out. Number 2, you have a lower respiratory tract disease where you have a viral disease, obviously from rashes, conjunctival congestion, cold, running nose, and a typical setting of bronchiolitis where first day you have cold, next day you have wheeze and hypoxia. This is a typical bronchiolitis and doesn't qualify for any investigation of a bacterial disease. My dear friends, do not worry. Don't hesitate. Relax and treat hypoxia because antibiotics are not going to make any change in the management. Number 3, you have a viral triggered lower respiratory tract disease, which is often asthma or no asthma. We call them as wheezing phenotypes, episodic wheezers, etc., where a rhinoviral infection will trigger a wheeze. And as soon as you give a bronchodilator, they get relieved. So what can I do when I'm in confusion? I have viral disease where I have a syndromic diagnosis, breaks, family, multi-system presentation, etc., which all of you know. I'm going to cut it down. But you have lung disease. If it is a predominant airway disease in the form of wheeze, etc., please hold the antibiotics for a while. If it is parenchymal disease and if it is a viral disease, how do I identify a parenchymal disease? You really need patience, grunting, localized retractions. These are not part of a viral disease, my dear friends. Therefore, in those situations, consider high probability of bacterial disease. You don't get a chest pain in a viral disease. You will definitely have a chest pain with pleurisy in a bacterial disease. So, my dear friends, if you have an evolution towards the bacterial localizing or non-localizing, airway or parenchyma, and the time taken for the cold to go to the chest, these are the evidences on which you should decide a viral disease or a bacterial disease and treat. I think I gave some hints. Madhibhai, there is no time because I can take this for 1 hour. Next time, I will just say how to differentiate a viral infection from a bacterial infection. Itself can be a talk for 40 minutes, but I made it very short. Now, third, the fever disappears, but the rest of the symptoms continue, like either hypoxia or wheeze or crepes. It is not a bacterial disease, but a fever continues on second, third, fourth day. My dear friends, it cannot be viral because a virus has a typical sudden surge and a down. And if you have these clinical inputs for you, you can differentiate between viral disease from a bacterial disease.
Thank you. Thank you so much. Now, there is a comment from one of our young, wonderful pediatric rheumatologists, Dr. Devasis Patra. He has mentioned if severe pneumonia with drop in hemoglobin, where the patient presents acutely, we need to revise the diagnosis of pneumonia. That's what he has said. Your comments, please.
Okay. Now, I will just come with one point. Whenever there is a drop in hemoglobin, it is not to be interpreted from respiratory angle at all. Now you are not a pulmonologist, you are a systemic pediatrician. Do the evaluation of drop in hemoglobin. Only disease for which there is drop in hemoglobin is some kind of crisis or acute hemolysis, or I would say a situation where there is hemosiderosis and autophagy and all those things. They're all quite rare, and some atypical diseases of some infections where you can also have hemagglutinin and all that. So I think we will keep that by the side. If there is a drop in hemoglobin, please evaluate for the cause of acute hemorrhage from a cavity, pre-existing, or a systemic cause, which is very, very important. Examine for spleen, look for tenderness, so on, smear, all those things. You have to evaluate. Rheumatologist is very much correct. I think we should know the cause of anemia, not the cause of respiratory involvement in that. You have to approach the disease from there.
And you can start thinking with atypical pneumonia.
Fair enough. Fair enough.
Yeah.
I agree.
Yeah.
Sir, why Dr. Devasis has asked this question? This is related to one of our case admitted in our unit. He is working in my unit. So what happened? This is a very interesting case going to be published. We have sent for publication.
Fantastic.
Ah.
Mrityunjay, what I wanted to tell is that atypical pneumonia also, this manifestation is infection-associated immune mechanisms.
But sir, we thought of everything, but finally it came out to a case of SLE. So, so therefore, Devasis Patra has rightly asked.
Fantastic.
So
Very good.
it was a case of granulomatous polyangiitis and with SLE manifestation, and we find out to be yesterday only the report came, and now the child is presenting with lupus nephritis. The early part of the lupus nephritis, stage 1, the child is in. So this is a very interesting case. We could not diagnose this. The child was.
No, nobody will diagnose. Don't worry. Many of them you need time. Yeah.
Finally, we
Never
ended
ever
up in
feel that
SLE.
somebody is good. It is only fortunately that segment. At that time, we are the pediatrician for that. Baby, if you are the pediatrician in the 3rd week, you will diagnose. If you are the pediatrician on day 2, it's not your stars to
We
make a
have done sir
diagnosis.
SPLC, we have done LDH, we have done all hemolytic panel, everything, this DCT, all done. And finally, the ground glass appearance in the CT came. From that, we thought something granulomatous disease will come, tuberculosis screening done. And finally, ANA came positive, then profile came dsDNA positive. And finally, we got that the urine coming protein plus, then hematuria, then now biopsy today done. And hopefully, this will come as a case of SLE with granulomatous polyangiitis.
Dr. Mrityunjay, what is the age of the child?
12-year child. The hemoglobin came down. Hemoglobin came down to 2.
So 12-year-old child is not what I have talked. My main focus was under 5.
Yes.
I just went little above 5. I agree on this point.
Thank you, sir.
Now, Dr. Braja.
Modi bhai, do you agree that we treat the age?
Yes,
Not
yes.
that disease. I think that's a golden line. Mrityunjay, that applies to your case also.
Thank you. Now, Dr. Braja, he has asked, why are children under 5 more prone to viral pneumonia than bacterial? And how does this influence antibiotic stewardship?
Okay. Viral diseases by and large are common in infancy, less common in childhood. There is cross-infection because of overcrowding of children, and there is a susceptibility. But as the age advances, there are 3 or 4 things that happen. 1, the prevalence of epidemiological prevalences of virus decrease. There is an immunological response to viral infections. The child's immunity grows with age. The way they handle the virus is also different. I mean to say, when you get exposed to a rhinovirus when you are 6 months, you get colds. When you are getting exposed to a rhinovirus in a train sitting next to you, you will not get the cold if you are a 26-year-old. So what I meant was that the risk of transmission is very high. The droplet infections also are more common in the younger age, and therefore we have high prevalence of viral infections. Lastly, the airway caliber also matures, and the so-called diagnosis of a viral associated wheeze will decrease with age only because of improvement or increase in the caliber of airways as the age advances. And you will also see that many of these children will visit your clinic 10 to 15 times in first 2 years. The mothers will disappear from your clinic by the age of 5 years. Modi bhai.
Yeah. Role of lung aspiration. Previously in 1990, I have done a lot of lung aspirations as it was my thesis. Role of lung aspiration in pneumonia.
Actually, I will just take this question from another. The gold standard for diagnosis of any infection is proving the organism at the site. This is a perfect surgical strike that we can ask for. Remember that even sinusitis, gold standard is the aspiration of the sinus. And pneumonia, same thing. But this was given up for following reasons. One, it is hazardous. The procedure cannot be done as a community approach. And when we should do the aspiration and where we should do the aspiration. This was, Lina madam, this was very popular in those days where pneumonia was thought to be localized disease and a disease of consolidation. You have a pointer from where you can do the aspiration. Now, what can I do if there is a bilateral wheeze and some kind of tachypnea where I have a setting where I have to give an antibiotic? That is
Yes,
when I don't think we can
I was
aspirate.
doing at the where the more percussion by percussion, there is a maximum
Now, my
dullness.
question is, if you have an evidence on percussion, treat it. Why aspirate it? That was the question.
Yeah,
And that's
only
why.
for academic
No, I
purpose we
agree
are
on point.
doing.
So, this I would say should be focused for research purposes,
Yeah.
for the purposes of ongoing proof of, rationalizing our empirical therapy and not for day-to-day practice. So,
Yes.
that's my answer.
Thank you, sir. Now, when should a follow-up X-ray be performed in cases of pneumonia that are not responding to standard treatment?
See, if you think that I have given 3 or 4 doses of antibiotics, let's say twice daily or 3 times a daily, I expect the bacterial disease to come down by at least 20-30% or 40-50%. What I meant was that one dose nobody will respond. So when I have hit 3-4 times, that means to say probably that is one. Second factor is the half-life or the multiplication ability of a bacteria. I'm not talking of a virus. Usually they double by 1 or 2 days. What does that mean? If the pneumonia is not progressive by 48 hours, taken as a logic of time from the ability of the bacteria to duplicate or multiply, and also the ability of the number of doses of antibiotics that could have been given by 48 hours. 48 hours is taken as a golden cutoff point by which we will review the diagnosis. Before 48 hours, it could be too early to say it is not responding. And after 48 hours, it is too late because there is no point in acting when everything has happened. So generally the children don't die. Even if they have complications or increase in the bacterial proliferation, if it is within 48 hours. With this assumption, we will take any investigation or a review at 48 hours. Modi bhai.
Thank you, sir. Now we'll take another question only. Dr. Sumanta Panigra, he has asked a question. I'm not very clear about it. May I request Dr. Sumanta, please unmute yourself and ask directly. Dr. Sumanta, please.
Can Sumanta bhai unmute because he is in the attendees list.
No, you have to promote him to panelist.
How to do that? I know.
I'll do.
Promote him to panelist link, then only you click on the participant, then promote him as to panelist, then he can speak. What is his question, Madhibhai? Let me see.
Yeah, Sumanta, kindly unmute and ask. Yeah.
Sir,
He is a professor HOD in medical college that is around 150
Pulwani.
kilometers from Bhubaneswar.
220 kilometers.
Sir,
we are in a
namaste,
setup
sir.
of-
Namaste.
Namaste,
Please
sir.
ask.
So we are in a periphery setup, like Pulwani, where we have a sickle cell cases are more here. And the type of X-rays and all this facilities are also not available 24 hours, or sometimes the X-rays are out of order. So in these cases, when the child is developing respiratory distress in age group 2 to 5 years, can you have a parameters like spino-scapular distances measurement or chest circumference difference management and restriction of one side, taking it as a complication of pneumonia, pneumonia effusion or empyema, as the empyema cases are rise here in here. So can that parameter can be taken as a clinical parameter in a resource limited place?
Sir, I would ask you, please ask the government or the private institution to invest on ultrasound of the chest.
That is the poor thing. We don't have ultrasound being a district headquarter hospital, and it is out of our hands.
Fair enough. I think if you don't have ultrasound and you have to go only on X-ray for diagnosis of effusion, then you will miss mild effusions and you will pick up only moderate effusions. That's one. In that case, I would request you to, clinically mild effusions like 20 ml, 30 ml, you can miss clinically, which we have to accept. Now, can I have effusion in absence of pneumonia? Answer is no. Only in TB you can have only effusion, no pneumonia. Generally, there is pneumonia. But by the time you have 30 to 40 ml of effusion, you will generally have signs of pneumonia, which you can pick up as head of the department or as clinicians. Number one. Number two, if you have more pneumonia and less effusion, then it is more likely to be staphylococcus. If you have less pneumonia and more effusion, then it is likely to be streptococcus. And I will tell you why. Staphylococcus is more locally malignant. It will destroy the lung before it invades the pleura. So you have more necrotizing pneumonia in relation to the given pleural effusion. I'm just talking, please understand, this is a very tricky line by me. Suppose you have more of effusion for the given pneumonia. It is streptococcus because it is not locally malignant. It invades both lung and the pleura simultaneously, and you have bacterial suffusion into the pleural cavity, which grows. And therefore, if you have moderate pneumonia, moderate effusion, I will focus on treatment of staphylococcus. If you have, I would say, large pneumonia and less effusion, I would consider on staphylococcus. I think why I told you more and less is because this is, I think you can use clinically. No evidence, moderate evidence of involvement, and much more evidence of involvement of lung and pleura. If you teach your students, I think somewhere you can help you to say, should I give anti-staphylococcal drugs or should I have to give anti-strep pneumonia drugs in a second line? This, I think, would help you. This is the last low-cost advice I can tell you to, intervene in absence of any investigation.
Another thing, sir, we have sickle cell cases more. So the organism, what you are telling, may not be common in this area. We get more the salmonella.
No, that call of epidemiology has to be answered by you only, not from Bangalore, because I will not know the prevalence of organisms. Then I will say, hands off, sir. You know better your area and your organisms. There I will leave it to you. Probably you can give it as a thesis for somebody and try and see if you
So
can
we
get some
don't have
evidence.
postgraduate. We don't have even undergraduates.
All right, just try and see.
Okay.
One last question, sir. Which antiviral, if at all, is recommended to be given in severe pneumonia? if at
Okay.
all.
If at all you want to give, you have to give oseltamivir. And indications for oseltamivir are: one, if there is an outbreak. Number one, if there is an immunocompromised host in an outbreak. Number two, if they are too young or too old. What I meant was that you have a setting of chances of influenza. The baby is too young, or somebody is more than 90 years, and you can't afford to miss oseltamivir for him. I'm sorry, crossing the age of children. Number four, if you have already proven laboratory diagnosis of influenza. So, but for these indications, empirical therapy with oseltamivir is not advised. Number one. Number two, oseltamivir will help if you give in early part of the disease, not in the later part of the disease, because already the damage is done. And please remember, oseltamivir is not that it should be rampantly utilized, because just like antibiotics, you can have emerging resistance for oseltamivir also. The chances of oseltamivir getting resistance is as good as cotrimoxazole getting resistant. So beware of these things and use oseltamivir.
Thank you, sir. Thank you for fielding a wide range of queries from the delegates. Now over to you, Dr. Mrityunjay.
Thank you, sir. Thank you, Subramaniam sir, for the elaborative discussion on pneumonia and lot of insight being cleared from the first picture of the elephant. Now we are able to understand where is the front part, where is the back part. And thank you, Professor Modi sir, for nicely moderating the whole day, whole session. And I'm thankful to Rawat sir for giving us this opportunity, this platform, and this NRC platform for
You can have many more.
Thank you.
I would love to come again.
Thank you,
I would love to
Subramaniam
come
sir.
again. Please give me the opportunity, because many pediatricians write back to me. I would compliment the branch of Orissa. Really, I will tell you, you people are too good. And maybe it's the effect of Jagannath. I would just steal the Jagannath from that place and bring it to Bangalore. Something can happen here as well. We are jealous of you. So in that sense, I'm very thankful to you. I would again come in a matter of a month or two. I would request Modi bhai, it is my request, please have one more webinar, probably on again a common disease rather than an uncommon disease of pulmonary.
We'll have surely.
Thank you, sir. Thank you. Sir, nowadays the Spokos machine is working very good. Our PG students, immediately they can know whether it is empyema or only pneumonia. That is working well. So that
I
also
tell you,
you
of
can
all
take.
the ultrasounds, lung ultrasound is the easiest.
Yes,
It is
sir.
easier than a gynecologist
And
ultrasound. It is easier than abdominal ultrasound. But people don't do.
yeah. No, that machine should be there in a government hospital. That only. Okay, sir. Thank you.
Dr. Subramaniam, few requests there from doctors that they please share the slide. So can you
I'll
give
share
us
1 minute. I'm sending. I'm sharing my number so that they can send to me. I'll share to you or to somebody. You can also in turn share.
Yes, sir.
I'll convert it to PDF and share.
Yes, sir. That
Okay.
is true. That is good. So thank
Because
you.
it will become less voluminous that you can share.
So
Mrityunjay, I
thank
will share
you.
it to
Thank
you.
you
You
to
can
all the
also send it
delegates,
to us.
and thank you everyone for attending, and thank you Modi sir again. Thank you Subramaniam sir. Thank you IAP Odisha for joining, and thank you Dr. Kasi. You are there. You were driving somewhere. Okay. So thank you everyone. So have a good night, and let meet again Subramaniam sir in the recent future when Modi sir will allow us again to conduct another one. Thank you.
Jai
Thank you.
Jagannath.
Thank you,
Jai
sir.
Jai
Jagannath.
Jagannath. Thank you, sir. Namaskar, sir.